This is an area that I think is of particular interest to me, and I think to a lot of pilots, aeromedical issues. Most of you know that ALPA frequently says the most important safety feature on an airplane is a well-trained, well-rested professional pilot. So now we turn our attention to that key safety feature, the airline pilot. Our next panel will talk about what's new on the aeromedical front in both the U.S. and Canada. You'll hear the experts talk about a variety of topics that truly impact every pilot in this room. Moderating the panel is ALPA's Aeromedical Chair, Captain John Taylor. John, take it away.
Thank you. John Taylor, once again, the Aeromedical Chairman, and it's a true pleasure to have Dr. Fraser, Dr. Salisbury, and Dr. Snyder up here as the experts within the aeromedical realm. Obviously, the key fact within the aircraft, and the most important part in my mind, is the pilot and the pilot's safety. And with that, we are going to open up to questions. Anybody would like to make one last statement before we continue on?
John, I just want to say, as many of you will soon note, I am getting over a cold, so I'm going to sound kind of froggy here. I'm in that stage where you feel better but sound worse. It's not Ebola. Everyone out there is safe. But just wanted to let you know that if I pause and clear my throat in the middle of an answer, I have a medical excuse.
You got a doctor's note today. The first thing I'd really like to congratulate you for is the FAR 117, the rest rules. A lot of the reduction in the special issuances, allowing the AMEs to issue. I think that's a progressive move within the FAA, and I truly want to appreciate the efforts you've made in that area.
Well, thank you, and certainly that's a goal of mine in my tenure as Federal Air Surgeon, to increase the number of conditions that we call CACIs, conditions AME can issue. So we're looking at more and more things that are stable that previously required the deferment that our AMEs are able to issue right in their office. And I am looking to do whatever I can to increase that number of airmen that go in to see their AMEs and walk out with their ticket. Presently, that's 90%. If I can increase that to 92% or 95%, that will be a huge pilot-friendly, AME-friendly thing, because it gives those of us that are FAA physicians more time to concentrate on the more complicated medical issues that get deferred to us.
Is there any other conditions that you're looking at right now on the list that you would like to expand?
There are a number of conditions, in particular some of the cancers, that we're presently looking at that we soon hope to turn into a CACI.
Mm-hmm. Dr. Salisbury, how do you think we compare to Canada with our interaction looking across the border?
Well, we have very different legal systems as to how we are required to handle these things. So we don't actually have a concept of a special issuance in Canada. The regulations are set up in such a way that the minister is allowed to give an exemption if an equivalent safety case can be made. And that's essentially how we handle all of our cases outside of the routine ones that are comprise a good 90% of what we do.
And of course, one of the big things that we see in the U.S. is diabetes has come back and it's in the rise. You treat it different than we do in the FAA, or at least in the U.S., correct?
We do. Diabetes is a worldwide problem. It's not confined to just the United States. Our entire human species seems to be in an outbreak of diabetes, particularly type 2 diabetes. About 20 years ago, we had a case that we had turned down, and that person took us to federal court and then took us to the appeal court of the federal court, which is one below our Supreme Court. And while the court backed us up on what that we had a good safety case about not letting that person fly. They indicated to us that we needed to take a more proactive look at each individual case as opposed to having a blanket policy that said no diabetic who's using insulin could ever fly. And so we convened a working group of the best specialists we could find, and we tentatively moved out into the world of allowing people who were using insulin to fly in certain very restricted circumstances, and also very special diabetics. They're not if the run-of-the-mill diabetic that one would see in one's office necessarily. They're under extremely good control. They don't have the wide excursions into low blood sugar and high blood sugar that characterize some people who are sometimes referred to as brittle diabetics. And the people we started with was a unique Canadian non-ICAO compliant permit that we have called the Recreational Pilot Permit. And that allowed them to fly light airplanes with only a single passenger. They were only allowed to fly day VFR, and that experiment worked quite well. And so we expanded that into allowing our ATPLs who developed diabetes to actually have insulin added to their treatment regimen under certain circumstances and allow them to continue to fly in a circumstance where they're required to have another pilot qualified on type in the cockpit. So we've now got about 15 years of experience doing that, and a little less than 100 cases at the ATPL level who've done that. And so far it's been a very successful experiment, and we're now, it's been the same process has been picked up by our colleagues in the UK and in Australia, I think, as well.
Dr. Fraser, where do we stand within the FAA standpoint? I believe we can have oral antiglycemics approved.
That's correct, John. Certainly if you're a diabetic and your diabetes is controlled with oral medication, you are readily going to receive a special issuance. And for quite some time, GA pilots that require a third-class medical have been allowed to fly with insulin-dependent diabetes with a very strict protocol. However, for ATPs, for first and second class airmen, we at present do not allow these airmen to fly with a special issuance if they are insulin dependent, and that's because of the risk of hypoglycemia, which unfortunately can be inapparent. The airman cannot realize that he's hypoglycemic, and he can be making mental errors and we think be a risk to the safety of the aircraft and the national airspace. Now, having said that, I am very proud of the fact that we are presently working with the ADA, the American Diabetes Association, and we recently met with half a dozen endocrinologists that specialize in diabetes, or diabetologists, if you will. And these are some of the brightest folks in the country. And of course, we presented the safety case and said from the beginning of the meeting that someday we, the FAA, are going to be willing to certificate that subset of airmen that are stable, that can demonstrate that they're not brittle, much like David was talking about, and that they are not likely to become hypoglycemic or get hyperglycemic. We're not there yet. The ADA is willing to work with us, and I'm convinced that the science will come. There's certainly new forms of insulin that are bimodal in the sense that they have other factors added to them. in addition to insulin, and there's new sensors that are getting more accurate and more timely. And much like what we did 3 years ago when we identified that subset of airmen that had been successfully treated for depression and were on an antidepressant, and we were willing to certificate those folks with a special issuance. I truly believe in the not too distant future, and here I'm talking a couple of years, not a couple of months, we're going to be able to certificate these folks when we can identify that subset that are well controlled.
Would this be a technical issue, as in the people actually monitoring their glucose in the cockpit with the new technology that's coming out, or are we looking at new medications that you're alluding to?
No, I think it would be more of a technical issue in the sense that there would have to be continuous monitoring. And in order to special issue these folks, we would want to see a log, which the new devices provide, that show that this airman is well controlled and is not likely to have a hypoglycemic episode. So, the medications are indeed getting better, but it's still going to be the technical aspect of being able to monitor and first assure ourselves that they're relatively stable, and then, of course, in flight, continuous monitoring would be essential, and knowing what to do if indeed they did have that episode of hypoglycemia.
Let's move on to one of the advancements that Canada has done. Is I've read your manual on OSHA, or OSHA Respect. How did you come about that in Canada, recognizing that pilots' safety and environmental impacts?
Okay, so all federal workers in Canada, or who are in industries that are regulated by the federal government, so that would include all the major transportation modes, the banks, some other industries, fall under the Canada Labour Code. The Canada Labour Code not only talks about employee-employer relationships, but it also talks about occupational health and safety. And the airlines and the transportation sector were not exempt from that when it was brought in. We actually realized that there were some issues to do with the ones as they were published in the Canada Labour Code, so we actually published a separate group that are aviation, occupational health and safety regulations, and most of that regulation is incorporating the Canada Labour Code standards by reference. But there are specific things where you don't, where the aircraft systems and the regulations have to be married up so that they don't come into conflict with each other. So there's a separate set of aviation occupational health and safety standards or regulations in Canada. Pilots, doctors, engineers, nobody's exempt from these considerations. So that's how that was brought in. The other part of it was that Labour Canada at that time determined that they really didn't have the expertise to walk onto an airplane and understand what was going on. So they negotiated with Transport Canada, and Transport Canada's cabin safety inspectors were deputized to enforce that part of the regulations. So that's how it's currently done. Those regulations exist. All workers are covered by that. All employers have to comply with it, and the inspection or follow-up or investigation of incidents is done by Transport Canada inspectors, mainly because they know their way around an airplane without walking into a prop or something. So you want to have that kind of level of expertise for the inspector who's going to deal with the workplace. But essentially the regulations are the same regardless of where you work.
And Dr. Fraser, I know we talked in April about this a little bit, you know, with the noise in the cockpit, the ozone, you know, the environmental impact that we have within the aircraft. And currently the FAA, if I understand this correctly, is in charge of that. Where do we sit there in the monitoring process of the environmental impact that a pilot sees day in and day out?
Well, let me start, John, by saying that I'm probably not the subject matter expert in this area, because we, aerospace medicine, certainly don't have that responsibility. And as I have learned more about this in the 10 years I've been with the FAA, it's really an interesting mix of people that have different responsibilities for the aircraft. And of course that differs whether you're flight crew or cabin crew. Up until recently, it's my understanding that OSHA had no role in our aircraft, but as of the latest reauthorization, OSHA was given partial responsibility for some of the OC health issues in the cabin. And I believe that's hazard reporting, bloodborne pathogens, and hazardous materials. But other than that, there are a lot of things, be it ventilation or ozone or flame retardants or whatever, that aren't specifically covered by OSHA, neither in the cabin nor in the flight crew. There are many regulations that Flight Standards maintains in Part 121 that deal with the OC health issues for flight crew. Likewise, if you're talking ventilation issues, aircraft certification and all of the engineers in Part 25 have multiple responsibilities for oversight for the flight crew spaces. If you're talking hazardous materials, we're talking either CDC, or in the case of pesticides, we're talking USDA, U.S. Department of Agriculture. So it's a real mismatch of different folks that have responsibility for the OC health environment in U.S. aircraft at present.
What do you think we could do to facilitate that and get it to the point where the daily pilot is protected and monitored and had the protection of OSHA that other employees have? Do you see that as a gap, or do you think the current regulations cover that?
You know, there was political pressure, if you will, that were responsible for the fact that OSHA assumed some of the responsibility for OC health issues in the cabin environment. And I feel that if the flight crew folks felt that their OC health monitoring was in need of improvement, then certainly at the time of the next reauth, your spokesman, your ALPA spokesman, and others could certainly get the ear of Congress and put that into reauth, and Congress, our bosses, tells us what to do. You know, I like the idea of our ASIs, our aviation safety inspectors, being able to do what David's do up in Canada, but I'm not sure that they would like it as much as I would like the thought that they would have the access and the expertise to be able to do that. So, you know, we're learning more all the time about the airliner cabin environment. And we, aerospace medicine, are in a supporting role, in a research role. For 10 years, we have cooperated with half a dozen different universities in the US and Canada, and have done some incredible research into the airliner cabin environment. So whether you're talking about bleed air byproducts like tricresyl phosphate, or flame retardants like polybrominated diphenyl ethers, we've done a lot of PhD type work that has certainly been notable and have moved the science of the airliner cabin environment a long way, but there's always room for improvement.
Thank you for that. That means a lot. You know, obviously, I know the FAA has worked with us over the years, and I think that there's a little bit of a gap there with the individual pilot day in, day out, with the noise, the radiation, and if that's the route that we need to go, I think that's something that we need to pursue. Not to change topics real quick, but I don't see any questions up there. Talking about the special issuance that still exists, how are we doing on the timeline? I know that there was a period of time where it was taking up to 3 to 6 months for people to get special issuance. It seems anecdotally that things have sped up. What have you done to facilitate that?
Well, we have certainly employed the expertise of the AIT, the folks in the FAA that control all the dollars that are needed for people to go in and fix our software. Last March of last year, 2013, we unfortunately had a new version of our electronic medical system introduced that was really a disaster. And because we could no longer work cases, when you see 400,000 airmen a year, it doesn't take long to fall behind. So we have worked with the IT folks, and the FAA has been very cooperative and magnanimous in giving us the support we need to fix our system. And even though the average wait time on a yearly average is still around that 30, 40-day average, looking at it since we've had DIWS, which is Document Imaging Workflow System, it's the name for our electronic medical system. In the latest month, we are under 30 days in terms of processing time, if you look at just that month and not the year-long average. So we've made market improvements, and I'm hopeful that with time, with education of AMEs, with the CACI process, as well as what we call AASIs, AME Assisted Special Issuances, that's where for the first time a airman may have a medical condition that needs to be deferred to the FAA. We are able to grant an SI and yet give the AME the specified follow-up and testing that's necessary to renew that SI. So thereafter, for the next 5 years, that airman simply goes to his AME with the specified follow-up and testing, and the AME renews his special issuance. So those AASIs, in conjunction with more CACI processes, will help as we educate not only AMEs but airmen that know that these more pilot-friendly modes of certification exist.
With the progression of the CACIs, and what do you see going forward within the flight surgeon office? Where do you want to go next to facilitate the pilots?
Well, I think I kind of alluded to that at the beginning, John. We've got 3,400 aviation medical examiners out there, and we work very hard to train them initially and then keep them trained with required education every couple of years, every 3 years to be specific. These are all physicians that have had a whole lot of training, and they're smart folks, and my goal as Federal Air Surgeon is to leverage the expertise of these AMEs and be able to give them the guidance they need to give an airman a CACI when he qualifies, or an AASI when he qualifies, and just reduce the number of deferrals. Our system works best when the airman goes in to see that AME and walks out with his ticket. So my goal is to increase from 90% to something more than 90% the number of airmen that have that happen.
You alluded to the deferrals, and it seems like a lot of AMEs recently, with guidance, have deferred to the regional flight surgeon. Do you go back and re-educate the AMEs when it wasn't necessary, or is it responsive, or how does that work?
No, we do indeed have a major role of oversight of AMEs, and that falls to the regional flight surgeons. The oversight of the AMEs is their responsibility, but certainly we track any cases that they inappropriately issue, and we counsel them when that happens. And what we have started doing more recently in the past couple of years is counseling these same AMEs when they defer, and when we review the case, it's clear to us that this could be a CACI, or this could be an AASI, or even that if he would have just called the regional flight surgeon or AMCD, our Aviation or Airman Medical Certification Division in Oklahoma City, and talked to a physician, we could have certificated the airman right then and there. So we are playing an ever stronger role in making sure these AMEs stay up to date, and that includes using these more airman-friendly CACI and AASI processes, and certainly calling one of us, one of the FAA physicians, and talking with us in terms of how we can get that airman certificated as quickly as possible.
What would be the biggest recommendation you would give to the pilot group out here to facilitate their medical if they did have a question? We obviously have Dr. Snyder over there who was with AMAS, and we all call him and with our questions. What is the biggest issue you see coming across your desk day in and day out that we could prevent?
Well, John, I wish that all airmen had a relationship with their AME, much like many of them do with Quay Snyder, or in the system I grew up with in the Navy, whereby we had flight surgeons that were intimately familiar with the airmen in the squadrons for which they had responsibility. It would be an ideal world from my parochial perspective if we had airmen that had that relationship, that were willing to go to their AME and treat that AME like a flight surgeon and say, hey, I've got this condition, should I be flying, or should I not be flying, or I'm taking this medication, is there anything I need to be concerned with? This is certainly difficult to do in a civil aviation world as opposed to in the Navy or the Air Force or the Army, but I would like to encourage all airmen to develop that relationship and that trust in an AME so that we're able to answer questions that we have the opportunity to resolve.
I jump in on that one. I think the other part of that is proactive. It's what you're talking about is proactive disclosure, but I think the biggest thing that slows any certification decision down is lack of information. Right. And when people don't give us enough what they know or what their treating doctors know, it's hard for us to make a decision in the absence of that knowledge. And so if I could press on everybody, the thing you need to do is give us the information. I mean, if we look back at when Jim and I started in this business, and we won't talk about how long ago that was, there were virtually any condition you could name, it would result in you being grounded. That's not the way aviation medicine's being practiced these days. I mean, we're seeing increasing numbers of different conditions that are being certificated and allowed to fly safely. And a lot of that has to do with our increased knowledge of disease process, but it also has to come with, we got to know what is actually going on with that person. And keeping the information, I don't think we'll ever get to the flight surgeon flying. And, Navy is okay, but Royal Canadian Air Force is better. The kind of relationships we had with our squadrons is a very different one. And being the treating physician as well as the one who's talking about certification has its own challenges into how you deal with that. But the knowledge is the thing that makes you decide whether things can be safe or not. And as a regulator, our problem is sometimes we're getting just a piece of the information while the spectrum of disease is so wide. You could end up with, well, some of those people are fine, but some of those people are not fine. And we need to know the details. And, you know, I would say when we look at our statistics, we're probably, of all the people who cross our desk, 99.5% of them are eventually get a certificate and go on flying. So, you know, it's not a system that is grounding an awful lot of people, but it is sometimes deferring a lot of people, and that takes time. And the reason that takes time usually is because we don't know enough.
The biggest challenge that we face in our office is getting the appropriate information so that the FAA can make a valid determination based on the facts. And many times the pilot is confronted with a problem in that the treating physician feels that a brief statement with their conclusion is adequate. But from a regulatory perspective, you need solid evidence. So obtaining that, sometimes the aeromedical standards are higher than just general medical standards or standards of care and require additional testing that either insurance companies are reluctant to provide or a physician is reluctant to do because it's not, quote unquote, medically indicated. But once we can communicate that with the pilot, or better yet, as Dr. Fraser said, if the pilot's AME will work with the treating physician to get that information, then it goes rather smoothly. But for the pilot who provides incomplete information, it really delays the process because the FAA is faced with reviewing that information, finding that it's inadequate, returning a note to the pilot via letter that you need additional information, and then we go through the process again. The FAA has done quite a bit recently to put the guide to AMEs online so it's available, and it has particular disease protocols that define what information is required to make those decisions. And the online AME guide is updated on a nearly monthly basis. Dr. Fraser's office works very closely with us with quarterly meetings. We provide feedback about areas where we see opportunities to improve. And I will say that Dr. Tilton beforehand and Dr. Fraser have been incredibly responsive to that, incorporating those changes quickly so that the process goes better, not only for the airmen, but also for the FAA certification process too.
Yeah, and we started out talking about diabetes. I mean, the way we let that subset of diabetics fly is by the amount of knowledge we have. All of them in our system have recording glucometers, so the log of their entire experience, whether it be on the ground or in the air, is given to us to have a look at, so that we know what's happening to them day to day. There's really no single test that would, if you give me, oh, well, what's the one test that will tell me whether that diabetic is safe to fly? There's no single answer to that. And Jim mentioned the protocol. In-flight, the in-flight protocol is fairly stringent, and it's because we have the same concerns that the FAA does and that others do about hypoglycemia and awareness. And so people are required under that special circumstance to take their blood in the cockpit while flying at a regulated interval so that we know and they know that they're not developing hypoglycemia. And there's actually protocols that say at what level of blood sugar do they actually have to carry a source of glucose with them. And if they reach that level, then they're required in order to take some glucose in order to make sure they don't get hypoglycemic. And all of that's spelled out in the issuance letter that they all get. And we monitor them very, very carefully.
With that, we're talking about a lot of technology that is coming out, and obviously the internet, everybody goes to WebMD or XYZ, Mayo Clinic for their self-diagnosis. We have the technology. Is there a way for a general pilot, especially with as many drugs that are prescribed daily, to access somebody's on I'm trying to think of a generic drug that they would take every day, which would be hydrocortisone. They got inflammation. And we know, through Dr. Snyder, there's a grounding effect. Is there a way we could get that publicly accessible for the general pilots?
And we have been working on that, John. I have the pleasure of working with a GA, Joint Safety Committee, and one of the issues that we've looked at was better access to information for airmen regarding different medications that they're taking in those times when they're taking medicines that are truly dangerous. I mean, I continue to be amazed at the number of GA fatal mishaps where forensic toxicology shows significant levels of diphenhydramine, which has a trade name of Benadryl. There's still a number of pilots out there, at least in the GA community, that continue to take these medications despite the fact that every aviation journal that I've ever looked at in my entire career, starting in the Navy and in the last 10 years of civil, have often talked about the dangers of over-the-counter medicines and the sedating effects of antihistamines in particular. So we have indeed expanded the AME guide that Quay alluded to. We have a pharmaceutical section that is certainly available to any airman. All you need to do is Google FAA AME guide. It's not a protected source of information. And you can go to the pharmaceutical section, and we've recently added a don't issue, don't fly for both airmen and AMEs, where they can look at categories of different medicines and know that there is a risk if they take this medicine, and it needs to be, they need to check with their flight surgeon or their AME if indeed they're taking this medicine to see if they need to ground themselves until they stop. And more recently, the GAJSC agreed to host a website where the members of the GAJSC, people like ALPA and EAA and organizations like that, are going to their physicians are going to work and host a website where they can take our pharmaceutical section and our don't issue, don't fly, and put that into airman speak. The AME guide, by definition, is technically for AMEs, for physicians, not for airmen. So we're going to make it as airman friendly and airman understandable as possible. It won't be an all-inclusive list. You would never be able to accomplish that. If you look at a physician's desk reference, you realize that there are literally tens of thousands of medicines out there. But certainly we can look at it by category and better educate airmen that have concerns about medications.
The other challenge associated with that is we probably get 40 to 50 calls a day in our office. Can I take this medication and fly? Our initial response is not yes or no. It's what are you taking the medication for? Because
Absolutely.
there can be a perfectly safe medication used for a condition that would be disqualifying by itself. So you really need to take a look at why is the airman stimulated to take that medicine? Why are they interested in doing that? And it's usually the underlying condition that is more significant than the medication. And each person can have an idiosyncratic effect with a particular medication. So a ground trial, if they've not been previously exposed to it, is also appropriate too.
And that's been the recommendation we've heard for years is there a specific amount of time that somebody should be grounded with a new medication even though it were approved by the FAA? I've heard 24, 72 hours, or is it just drug by drug or case by case?
Well, I would say it's case by case, but certainly I appreciate Quay pointing out what I should have pointed out from the get-go. It's really the underlying condition that's important and not the medication per se. Certainly there's many medications for which there's no recommendation for a wait time, but on the other hand, if you're starting a new antihypertensive, for instance, that could cause you to be lightheaded. And it's very wise to be able to take this medicine for a week or two before flying. Another common example of medicines where we expect a time period would be switching to one of the oral anti-diabetes agents. Certainly those folks are asked to have a wait time before they resume flying in an aircraft.
And to go back to the topic that you brought up earlier is the SSRIs. How is that program working on your side? We've had multiple pilots come through the program. Obviously their life is better. Do you see any issues going forward, or is there anything that we can improve?
I am very proud of the very small role that I had as many of us at the FAA were able to develop this policy. We have several hundred airmen now that are flying with special issuances for adequately treated depression. Our success has been such that we are now looking at medications, different SSRIs or different antidepressants than the 4 that we originally required airmen to take before they be considered for an SI with this condition. We're also looking at other conditions like obsessive compulsive disorder, for which airmen are sometimes given SSRIs. So we are looking at expanding the program, because even though we have several hundred very successful stories at present, if you look at our American population, you realize that the several hundred airmen that we're certificating now are still an inadequate sample of the amount of depression that exists in the general population. 15% of us in our lifetime are going to have a major depressive disorder. 10% of us at any one time are having depressive symptoms, and 10% of us, in America at least, are on an antidepressant, mostly SSRIs. So if you look at the number of airmen we've SI'd, we're nowhere near 10%. And airmen are a microcosm of our general American population. So as we continue to operate this program, and airmen are more and more aware of the fact that they can continue their career in aviation if they'll work with the specified follow-up and testing we require, we expect that percentage of airmen that have these SIs to more closely approximate what we see in the general population.
John, I think the example of the SSRIs is an excellent example of the cooperation and the response to emerging technology. We had concerns about the initial implementation of the SSRI policy. We had pushed for that for a long time because we recognized that the old policy had selected the least safe pilot to remain in the cockpit, those who were depressed but not taking medication. And we left pilots who were cognitively impaired flying, while those who were cognitively doing better, emotionally doing better, resting better, were grounded. Or we had a third population that was taking the medicine surreptitiously without monitoring, and they were probably the least safe. But once the FAA instituted the policy in April of 2011, there were still some barriers there. The amount of testing that was required, the cost of that testing, the duration of the monitoring. So there was a huge disincentive for a lot of the pilots to take advantage of the SSRI protocol. With additional study, the FAA has reduced the amount of testing that's required to make it substantially less expensive, much more convenient to schedule. The observation period required has been shortened from 12 months to 6 months, again, removing these barriers. And it's just another example of, as David talked about earlier, you get enough information, you're able to track this, then you can make changes in policy that not only improve the safety of the national airspace system, but the health of the pilots, both physical health and in many cases the financial health of the pilots too. We have a long history of this. Coronary artery disease used to be disqualifying, now it's just common. You're going to go back and fly. HIV, seropositivity was disqualifying. In 1997, that was changed. And it came incrementally, and now it's just so routine. We're moving forward with sleep apnea now, and I think the FAA has yet to announce, but from what I understand, has a very, very good policy that makes sense, yet is still pilot-friendly. So.
With that was my next topic, was sleep apnea. Do you want to address that today?
Sure. It's certainly an elephant in the room, and I expected that question. As many of you may be aware, last November, my predecessor, Fred Tilton, great guy, wrote an article in the Federal Aviation Medical Bulletin talking about the fact that we were making proactive steps to look into those pilots that had a BMI of 40 or greater because of the significant risk they had of obstructive sleep apnea. And of course, obstructive sleep apnea is one of the causes of fatigue, but in our increasingly obese society, we're seeing obstructive sleep apnea more and more commonly. And the common statistics that I see are at least 2 to 4% of females and 4 to 8% of males, and some medical sources say much more than that. So in a proactive fashion, or what we thought was a proactive fashion, we proposed further screening of airmen that had that BMI of 40 or greater, and there was great hue and outcry that went to congressional levels, and we certainly backed off and pled guilty to not working perhaps with our industry stakeholders as closely as we should have. But we had the meeting with ALPA and many of the other industry stakeholders early last year, January, I believe. And following that, we agreed to a significant compromise whereby we would want to see further evaluation of airmen, not just that had a BMI of 40 or greater, but those that had the history of symptoms, and signs. So we now have our draft policy that ALPA and others were able to look at and provide comment. We have basically addressed ALPA's concern as well as all of the other industry stakeholders that had concerns about our policy, and it's ready to go. It's been vetted by my boss, Peggy Gilligan, and we've, in different colors, very methodically put which industry stakeholder had these concerns and how we've addressed this in the new policy. But the delay now is the fact that one of the compromises was that when we ask for further evaluation for an airman that has that group of history, symptoms, and signs, we will let the airman have a regular issuance while we have the further evaluation accomplished. And we are working with our IT folks to be able to change our electronic medical record to be able to track these airmen where we expect to see further evaluation and possibly further testing, because our system is set up to track airmen that get deferred. So when we agreed to allow airmen to maintain a regular medical certificate at the same time they get a letter from me saying we expect further evaluation and possibly treatment, we had to get an electronic fix so that all AMEs will manage airmen in the same fashion and will be standardized and consistent. And making these changes requires subject matter experts to do the software changes. So we hope to be ready to go by the end of the calendar year. The policy is written and we're ready to put that in the AME guide, and I think we'll make the national airspace safer when we have an appropriate screening procedure for obstructive sleep apnea.
So at the end of the year, it will be, with the new program, it will be non-grounding as long as the pilot is seeking treatment.
Well, and of course, one of the other compromises that we made was that the airman need only see a physician, not a sleep medicine specialist, but need only see a physician, his primary care provider, or perhaps a sleep medicine specialist, but any physician can evaluate the airman, look into his constellation of past history symptoms and signs, and tell us if he's at risk of obstructive sleep apnea. So we are allowing any physician, not just an AME, to be able to tell us if he feels that the airman is at risk of this condition called obstructive sleep apnea. And if so, then we would want to see further testing. And of course, this could be as simple as a home test, which is accepted by Medicare. So it's certainly standard of care, cost a couple $100. And of course, there were lots of folks that pointed out that if you get the full polysomnogram, that where you get the overnight study, that could be a couple $1,000. But we would only want to go to that level of testing when it was truly indicated by that constellation of history, symptoms, and signs.
And you're alluding to that would be off the BMI. Is that not the neck circumference anymore?
The BMI and excessive BMI is certainly one sign. Excessive neck circumference is another sign. If you have what they call a retrognathic jaw, a really receding jaw, that's yet another sign that you could be at risk of obstructive sleep apnea. But all of those signs aside, based upon input from our industry stakeholders, we're still going to expect a history of people that say that they snore or their wife won't sleep with them or they wake up tired and are unable to concentrate or have symptoms of waking up but they're gasping for air. And we're putting it all together. There's no one magic yes or no in terms of putting you at risk for obstructive sleep apnea.
What's important, John, is that despite the hue and cry that came out after Fred Tilton's Federal Air Surgeon's newsletter, the outcome has been really very positive. One, we have a streamlined process, but the health of the pilots is substantially improved because we've removed the disincentive to get the evaluation for the sleep apnea, which existed even before Fred's mentioned in the newsletter. So now we're seeing pilots that previously were hypertensive or had cardiac diseases or had different conditions, fatigue, that now don't have that anymore. They're coming off their medications. Their lives are so much better. And the most common comment that we get in our office from pilots who we've recommended get evaluated, they get treated is, I never knew I felt so bad until now I feel so good. And it's almost a universal comment after they come back from treatment. So their health is improved, the safety of the airspace system is improved, their career longevity is enhanced.
So if there's a good thing about being corrected in terms of our aggressiveness to be proactive, it is indeed this recognition of pilots that obstructive sleep apnea is a very real issue, not only for safety, but in terms of the folks that have hypertension and heart attacks and sudden cardiac death due to this obstructive sleep apnea. So we feel very good about the fact that we've raised the awareness of the risk of obstructive sleep apnea.
And there's also a pilot safety brochure that's available on sleep apnea that's been updated, and it's very good.
With that, does anybody have questions that they would ask?
There's some text questions available.
Oh.
Yes, we have a couple of text questions from the floor. Let me read one to you. I would like to hear the stance on the psychological issues. Pilots self-diagnose their fitness to fly versus the doctor's diagnosis, whether a pilot is fit to fly, and the reporting requirements on the 8500 form when a pilot self-diagnoses. So I guess he's looking for some general attitudes on that from the panel.
Well, there's an old saying in medicine that a doctor who treats himself has a fool for a patient. And I would suggest that pilots who diagnose themselves have a fool for a patient. Yeah. Yes, I'm all in favor of, check out how you feel. Am I safe is a good acronym. Those are good things to do, but diagnosing well yourself and as to whether you have a treatable condition or not, I have to say is not necessarily the best thing in the world for anyone to do, including physicians.
It's also a reason to have a good relationship with an AME or the resources of the ALPA Aeromedical office, where you can talk with someone, understand that what you're perceiving or what you've read on the internet may not be exactly correct. There may be other options that you should consider, some dangers that you haven't considered, and to take a look at those. If you go to an AME that will work with you, then there's no disincentive to discuss that question. Many treating physicians who aren't AMEs aren't really aware of aeromedical standards, either the legality of taking some medication or the physiology associated with aviation. And so they may give honestly and well-intentioned advice that's totally incorrect. So having those opportunities to discuss this with someone who has expertise in aerospace medicine is probably the best way to do it, and to be able to do it without fear that there will be a reporting requirement. Contact in the United States, contacts with healthcare providers are a reportable event, but with the appropriate documentation or the appropriate relationship with the AME, that's a no-risk issue for the pilot. And we would encourage them to talk it over if there's any doubt in their mind. The I'm Safe checklist works well, but self-assessment, although it's good and it's required, is not always complete.
And I would certainly echo the comments of my colleagues. The answer lies in the I'm Safe checklist and the honest self-assessment. There have been incidents that I'm sure you're all aware of where there have been psychotic events in the cockpit, or a pilot or first officer has been locked out of the cockpit. And there are always inevitable questions from the press. Gosh, FAA, why in the world did you let this happen? Why didn't you prevent this? And there will be people that will actually recommend that we do a thorough psychological evaluation at each and every medical examination. And we, of course, say that is not going to help. That's not a solution, and it never will be, because certainly these things are impossible to predict sometimes. And even though we depend upon airmen to be honest and forthright and ask questions about prior hospitalizations and mental disorders and things of that nature, there are those subset of folks that have not had that could indeed have psychiatric issues, and we will work with those as the issues arrive. But the solution lies in self-assessment, not in any kind of regular psychiatric assessment.
John, you have a gentleman with a question out there.
If you're ready for me, Ken Plunkett, I'm with Delta Airlines. And I'm really pleased. I have a great relationship with my AME, only I kind of stumped him. Last year, recovered from a pinched nerve, and with great treatment and therapy, with physical therapy, I was able to get back and get my range back, and actually have my range of motion measured. Found out that, unfortunately, I'm kind of old, and as you get older, your range of motion decreases. And I'm finding out now that we're about ready to put these little devices on our windows that are exceeding what would be a normal range of motion for a 62 to 65-year-old. how would I get, I don't know if the medical folks or the aviation-related people have different studies to find out, I mean, how far can we go on these windows before we're going to get problems with overextending necks and have neck and pain-related issues. If there's somebody in Aeromedical I can call and find out, I'd be great to, love to hear it.
I'll be honest and say this is the first time that I've heard of that as an issue, but certainly we at the FAA have consultants that we regularly use, including orthopedic surgeons and others that would be subject matter experts in range of motion issues of this nature. And we have actually, both in airmen that need a first-class medical certificate as well as many, many second and third, are able to use what we call a medical flight test, where an airman goes up on essentially a check ride and has to demonstrate that he can do all of the operations required in the cockpit safely. So certainly if any airman can demonstrate that, we would readily certificate them.
And Delta has a great relationship doing the medical flight test in the simulators there. And although Jim said it's like a check ride, you're not getting V1 cuts or anything like that. It's a person who's observing you doing routine pilot activities and emergency activities. And Delta routinely cooperates with the FSDO in Atlanta to use their simulators, and we don't have any problems getting pilots evaluated for conditions that there may be some doubt about whether they can do all of their routine and emergency duties.
Mm-hmm. We'll go over to this side.
Hi. First of all, thanks so much for all your efforts. I appreciate it. Pilot for United, and I was just curious. My name's John McFadden. The FAR 117 issues. I texted this in as well to the number. To what extent do you believe, if any, FAR 117 may have actually increased the level of fatigue? And are your conclusions borne out by any of the ASAP reports that are coming in? That would be the first one. And the second one is, do you know of, or are there any currently ongoing, any type of research that's being done to validate that 117 is actually decreasing the level of fatigue in the cockpits? Thank you.
Well, that's a good question, and let me say from the get-go that the people that really put 117 out are the flight standards folks. We, aerospace medicine, played a supporting role. We have a big civil aerospace medical institute in Oklahoma City, and they have some very smart PhDs there, some of which subspecialize in fatigue. So they were involved in some of the studies that involved the development of the flight risk management tools that all the air carriers use now. I'd be interested to talk with you in terms of why you believe that these rules have actually increased the amount of fatigue, because I know we are continually dealing with the cargo pilots who feel very left out and that they weren't included in all of the flight duty and rest rules, as well as many of the flight attendants that come to us through their politicians that feel that there should be mirrored requirements for them that allow them to work with the same flight duty and rest rules that the airmen work with. So I will certainly be willing to pass that on to the folks at the FAA at headquarters who work flight duty and rest, but I am not aware of any allegations that it's actually increased the amount of fatigue.
Thank you.
Yeah, if I could piggyback on that just a bit, where do we stand with the cargo carriers? Is it still stagnant, or are we looking at expanding FAR 117 to the cargo?
You know, that's a question where you're going to get me in trouble, John. But certainly, certainly those of us at the FAA, all of the pilots in flight standards that have been there, done that, and those of us in aerospace medicine know that from a human perspective, there's no difference between cargo pilots and those that are flying passengers. But there is a significant political side of the issue when the cargo carriers tell us that they'll be bankrupt if they're expected to adhere to the same rules that the other pilots are required to adhere to. So I'm going to leave that for the political arena, and just tell you that it's not those of us that are in the trenches at FAA headquarters that are against it. It's a OMB and a political issue in terms of the cost of making those changes for cargo pilots.
But at the end of the day, safety is always our number one goal, right?
That is indeed the FAA's number one goal.
Yeah. Got a question over here?
Hi, let me just start by saying very distinguished panel here this afternoon. My name is Murray Monroe. I'm the Canadian Pilot Assistance Chair. And so I guess my question would be directed to Dr. Salisbury, and it's kind of a multi-level question regarding DSM-5. If an individual is diagnosed under the new DSM-5, what are the expectations from transport about how treatment options will be considered? For example, education versus outpatient treatment versus full inpatient treatment programs. What level of reporting and feedback will be needed for each of these category of diagnoses? And what level of follow-up monitoring will be needed or expected by transport? And last but not least, when would we be able to expect some guidelines on the Transport Canada website regarding alcohol abuse disorders?
Glad that's your question, David.
Yeah, okay. So first of all, for those of you who don't know what some of that question was about, is that recently the psychiatric world was kind of turned on its head a little bit by the introduction of a new diagnostic and statistical manual, and it's DSM-5. And one of the major changes in that was the way substance abuse disorders are both diagnosed and categorized. And it doesn't quite line up with the way we've traditionally talked about that. Our read on that is that there is no substantive difference in the way you make the diagnosis. And if you look at the DSM-5 categories, and you can make parallels to what was in DSM-4. So there really isn't going to be a change in policy from our point of view. Our approach to substance abuse has always been, and I think will continue to be, that to begin with, it's disqualifying. And then, okay, you get together with your treating physician, your AME, and usually your employer, to come up with a mitigation strategy that you more or less sell to Transport Canada. We're not going to come out with a policy telling people how to practice medicine. We're not going to come out with a policy that will tell you exactly X, Y, and Z. There, I just proved I'm a Canadian. What you have to do. I think that's counterproductive. And by the way, as you all know, if you think it takes a long time to change regulations in the United States, I can tell you it takes just as long as to do it in Canada. I don't see a car change on that. I don't see us making a major difference. We have always taken the stance that people with significant substance abuse disorder issues can be treated, safely put back in the cockpit, but it's a tripartite agreement that basically says this person's got their act together and they are under control and that they're safe to return to the cockpit, and that's how we're going to stay. And again, I don't see that that's a change in policy. As to updating my website, well, if you have any political pull, you could write your member of parliament and ask him whether I could updating my website is sort of the last of my priorities at the moment, and I was interested to hear Jim talk about his IT problems. I can tell you that the 49th parallel doesn't change those. I mean, it's a constant battle to keep the electrons going where you want them to go. And website changes in the government of Canada are right at the moment huge. And I mean, it's almost daily, I almost log in every day just to find out where did my website move to today. And hopefully that will settle down later this year. And we're thinking about, in terms of putting together some kind of a working group on larger issues to do with substance abuse, because we're now faced with a new reality about medical marijuana and a bunch of other things where people are saying, well, these things are legal, so why can't people fly with them? Well, yeah, treating you with morphine is also legal, but I don't let you fly on it. Drinking alcohol is also legal, but I don't let you fly while you're drunk. Taking medical marijuana and flying is probably not a really good idea. But we need to get some guidance on that, both on the science side, but also on the legal side, because we're going to have to look at that. And the big issue with a lot of these other drugs is more or less we can predict when alcohol goes into your body and when it leaves your body and when you're going to not have a residual effect. That's not true of these other medications or substances. And so that's a long, rambling answer to say I don't see us having changed with DSM-5. The names put on the diagnoses are essentially changed a little bit. But our policy with respect to who we'll allow to go back into the cockpit is staying the same.
Okay, thank you.
I'd also like to comment too that the FAA just renewed the contract for HIMSS so that we can continue the education process of AMEs, medical professionals, pilots and airline management about the hazards of substance abuse and a pathway to get back. So we have a new contract and with one-year contract and possibility for a 3-year extension. Any of you all are interested in it, our next seminar is the 8th through the 10th of September in Denver. And I think it'll be a very, very good seminar. It continues to improve every year.
Yeah, and I just have to say, I am very proud to be a itty-bitty, teeny-beeny part of this HIMSS program, but since the FAA started working with ALPA and the various air carriers many, many years ago, we have now been able to put literally thousands of pilots through successful treatment, rehab, and aftercare, and have safely returned them to the cockpit. And we are frequently asked to travel throughout the world to talk to other air carriers in foreign country to tell them how we've been able to achieve this, and it's not just pilots, it's physicians and it's others that are concerned about substance dependence, substance abuse problems in their population, and to have been just a teeny-weeny part of that makes me very proud.
And we're over 5,000 pilots now that have been returned to fly safely with diagnoses of alcohol dependence or substance abuse. And just yesterday, Chris Storbeck, the National HIMSS Chairman for ALPA, and I were asked to go speak at the American Psychiatric Association here in DC for their police and firefighters group. They don't have a program at all. They certainly have the problem, but they don't have a way of dealing with it. The questions were very perceptive, and the comments about the comprehensiveness and the success of the HIMSS program were very, very gratifying. And I think that you'll see other industries adapting the HIMSS model, much like the physician community did about 20 years ago.
And we basically follow the HIMSS model, we just don't have the neat acronym for it.
It's all right, the acronym was designed to confuse.
Mark, we have another text question.
Yes, we do. This one is from the floor. It says, for any member of the panel, you say the most difficult part of making an accurate assessment of an airman's health is getting the information. With more and more of our health records being stored electronically, could you foresee a move in the future to require all airmen to give access to their medical records to their AMEs?
Well, I'll start with my parochial opinion, and based on my experience, the answer is no. The Patient Privacy Acts are pretty doggone strict, and we have to be very careful and squeaky clean when we handle medical records, and that includes medical records of airmen. So the requirement for airmen to provide their record to their AME, I don't think you're going to see in my lifetime.
Nor in mine. We have similar issues in Canada with respect to privacy and health information disclosure, and I don't see that kind of a compulsory law as being actually necessary for us to do our job either. I don't need to be flooded with information of everything that's ever happened to you as a pilot, but when you have a particular condition, I do need to know what's going on with that one in order to make a certification decision. But I don't need your complete medical record in order to do that. And I think having any kind of a law like that is not within the foreseeable future, and I don't think the various privacy information people who think about these kinds of things are even thinking that way in any way, shape, or form.
I'll comment not on the regulatory aspect. I agree with Jim and David on the regulatory part, but the problem we see is when pilots are asked to provide medical records, some of the electronic health record systems generate the entire file. The Mayo Clinic is famous for that. Very, very, very detailed records and very comprehensive. You need 2 pages, but you get 400 pages. And the other problem is that there may be errors in the medical record that are not corrected, and they tend to propagate over time and become legendary within the person's record. And when we review those records, we realize that that's not an appropriate diagnosis, but we have to go back and go through a correction process. However, you can't delete entries from the medical record, so the correction involves another visit to the physician to document that this was an inappropriate diagnosis, to have that available. So I do see that as a problem with the medical records, although I agree, I can't imagine in my lifetime that it'll become mandatory, at least under the current governments we have.
And with that, it brings up a good point. When we fill out our FAA physical now online, it doesn't self-propagate. It doesn't have memory. For example, I saw my doctor last year for the flu, and I have to remember that. Is there any way we can work on that?
We are indeed working on that, and we are very hopeful that we will be allowed to propagate that information that does not change. As you might expect, there's a legal side to this. There have been airmen in the past that talked about the fact that the form was such that they didn't understand it, and they had put no to all the answers before, and they put no to all the answers again, despite the fact that they may have had a heart attack or a psychiatric admission or something of that nature. So the lawyers tell us that, it's a good idea to have the airmen actually go through that list and read the questions that we ask rather than self-propagate with all no's, which has been successfully legally argued and we've lost.
But the same pilot who's on the same medication for life, so to speak.
Right, absolutely.
It forgets that one time.
Yeah.
That's a catch there. Mark, we have another text?
Yeah, we sure do. This question is directed to Dr. Snyder. What happens when a pilot calls the Aeromedical office Would you describe the process that your office uses to handle an individual case?
Certainly. When the pilot calls, we determine if he or she is eligible for services and valid ALPA member. We validate the demographic information to make sure that we can reach back to them. One of our telephone technicians takes a 1 or 2 sentence synopsis of what the medical issue is and then electronically sends it to one of our physicians for a callback. We try to call back within an hour, and sometimes on Mondays or Tuesdays after a holiday. It's a little bit more challenging. Other times we can get back right away. The physician will then discuss with the pilot what the problem he or she has. There may be an interim step. If the pilot has received a letter from the FAA, we will ask them to fax it or email it to us in the interim so that we can look at the letter and give them the best advice. If they have a condition that is a simple question, can I take this medication and fly? After we've gone through the appropriate historical review and discussed the FAA policy with them, that's the end of that call. However, a lot of pilots will have conditions that have reporting requirements or will require further evaluation. We have the capability of generating an electronic letter to them, usually within 2 or 3 minutes, to email to them with a checklist of all the information that will be required from their physician, a copy of the FAA protocol, all of our contact information, and release information so that we can interact with the FAA on their behalf or anyone else they designate, frequently their primary physician. When we receive records back from the pilot, we reach back and contact them about our assessment of what those records contain, whether their current condition would allow them to apply to have their medical reinstated if it was negated by their underlying condition, or whether it's simply a condition we can report to them prior to their next physical to make it easier on the AME. And occasionally we need to tell a pilot that this is a condition that may not be waiverable. They have a psychosis or some condition like that. But it's important for them to know that information early in the process so they can make the appropriate planning. We can also direct the pilot to ALPA resources, perhaps the retirement insurance people, if that's a condition that they'll be using long-term disability for. For pilots who have gotten themselves into some sort of trouble with the law, we can also recommend the contract administrators at the MEC or sometimes at ALPA headquarters with the attorney's staff. But overall, what we're trying to do is get back to the pilot within an hour with a complete answer, not only with respect to their health, but also with respect to their requirements with the FAA and their certification, and to assure them that we will be an advocate for them as a liaison between them and their physician and with the FAA. We have a great working relationship with the folks at the Aeromedical Certification Division and at FAA headquarters in that our staff will send a list every day of our cases that are pending down there, and particularly near the end of the month when pilots might be grounded. The FAA is extremely good in getting back to us and taking action to make sure that pilots don't lose the opportunity to fly because of some administrative issue. And then we'll provide the pilot a copy of that letter. And if there's a requirement to follow up in a year, 9 months later, we'll send them a reminder that, hey, it's time to look at getting your appointments rescheduled so that your special issuance doesn't lapse.
We have a question.
Thank you very much for a very candid and open discussion of some interesting subjects. My name is Réal Levasseur. I'm with the staff in Ottawa, Canada, with ALPA. You seem to be all in agreement that obesity has a relationship to sleep apnea. Now, some people do snore more than others, and that doesn't seem to have any relationship to your weight or obesity. Other than telling your spouse, put some earplugs and live with it, is there anything medically that works? You know, there's a whole bunch of charlatans out there who say, try this, put something on your nose, sleep on your slides, sleep on your back. Can you give us a little bit of your expert opinion on what would work for somebody who snores? It doesn't affect your fatigue, but it certainly affects your spouses.
There's a recent article in the New England Journal of Medicine that says it's called the elbow sign, and it's supposedly very, very predictive of people who have obstructive sleep apnea. If snoring isn't always obstructive sleep apnea, it's one of the signs, and you know, there are effective treatments for sleep apnea. CPAP is I think the gold standard at the moment. From what I've heard and what I've read about many of the proposed surgical approaches to it, I wouldn't recommend you go there. Let's just leave it at that. There are effective treatments, but you need a full workup, and you need to find out whether those treatments will work for you. You can't make just a blanket statement, because not everybody's sleep apnea is caused by the same mechanism, and you need to know what it is and why it exists, and then the appropriate treatment should be prescribed and followed. And certainly, if it is followed, there's no reason why that isn't compatible with certification for flying, at least in Canada.
I would recommend go to a board-certified specialist in sleep medicine or ear, nose, and throat to do it, so that you make sure that you have a quality evaluation from an expert in the area.
Thank you very much, Dr. Fraser, Dr. Salisbury, Dr. Snyder. I think that was very informative. I've learned a little bit. Hopefully everybody else picked up a little bit here, and I really do appreciate your time.